Hello and welcome. I'm Dr. Keith Lynch, and what I'd like to talk to you about today is how we help people who have chronic knee pain. Now, in our office, when we do a knee pain evaluation, what we're doing is we're doing a full neurologic and orthopedic tests on the knee, as well as x-rays of the knee, both from the front and from the side, so we can evaluate exactly what's wrong with the knee. So what we do is this. When we do a neurological evaluation, what we're doing literally from head to toe, we're checking your neurology, your cortex, your thalamus and basal ganglia, cerebellum, your brainstem, spinal cord, peripheral nerves and receptors. Now, why would we do that? What does all this have to do with that pain that you have in your right knee? Well, if you're like about half the people that come in here, you didn't have any trauma that started your knee pain. It just kind of came on gradually in one or both of your knees. No trauma, no sports, nothing like that. What it could be from is a breakdown in one of these areas of your central or peripheral nervous system. And what that'll lead to is when we're testing your receptors, your peripheral nerves, we're looking at how well you have sensation down in your legs and feet. So there are several pathways that we evaluate. Your small diameter afferent nerves are the nerves that bring pain and temperature up to your brain. Most of the time, those nerve pathways are intact. However, when we check your large diameter afferent nerves, these are the ones that are very metabolic. They require a lot of oxygen and glucose to stay healthy. Their role is maintaining pain-free levels in your body. So they actually work on your pain inhibitory pathway. And in health, that's what happens. Over time and due to problems with your body, they can break down, leading to conditions like peripheral neuropathy. That's when someone has pain and temperature issues with their feet. Sometimes it'll be burning, sometimes they'll feel like ice. Either way, it's pain uninhibited up to the brain from the feet. A condition that you can have similar to that regarding knee pain is when you lose the ability to feel what's happening down in your feet and ankles. And then what happens is you start loading that knee joint in an improper way and you get bad biomechanics. Bad biomechanics leads to a breakdown in the tissue. So when we do an evaluation, we're testing you neurologically as well as orthopedically. Now, in orthopedics, what we're really doing is we're looking at the joint the way it's put together. The femur or top bone in your leg, how that attaches to the tibia right up here on the tibial plateau is where your menisci are and where that femur head sits right on top of. And then we've got your patella, and then you've got ligaments, which come in from the inside and outside of the knee. And I didn't draw in the ones in front and back because then you wouldn't be able to see the other structures. But basically, when you're doing an orthopedic evaluation on somebody, what you want to do is you want to stress all of these structures to find out what elicits pain. Because if you can do that through consultation and asking the right questions, as well as doing a functional examination on somebody, you can identify which structures are actually damaged or injured, and then you can do something about treating it. Now let's talk about the way that most knee pain is treated here in the United States. There's a couple things that they do for it. One thing is that you'll get physical therapy, and they'll give you exercises to do, maybe some stretches, maybe some strengthening. Or they'll put you on pain medication, or you'll do injections. I know people that get very expensive injections, and they give them some pain relief for anywhere from 1 month to 6 months. And then they go back and they do another one. Most orthopedists will only do 3 injections. After the 3rd injection, they tell you it could damage the joint to do further injections, and they recommend either arthroscopic surgery or a total knee replacement. Now, arthroscopic surgery is where they go in and they use a scope and they cut away some material that's been injured or damaged in that joint. Seal it up, send you out, you get some therapy afterwards. A lot of people do get some temporary relief when they get that that treatment done. Other people get full knee replacements, and I'm going to show you an example of one of those in an x-ray that's hanging up behind me in just a few minutes. What I've found with the patients that I've worked with is this. They've been everywhere, tried everything. They've done physical therapy. They've had arthroscopic surgery already. Some of them have even had total knee replacement and still have the pain. There was a journal in the New England Journal of Medicine, I think it was 2009, that said 50% of all people that they polled that had a total knee replacement, only 50% of them said that they had meaningful improvements after they had their surgery. So what's that mean? It means half the time, maybe the procedure wasn't the right procedure, but that's what there is offering to you. So most of the patients that come in here recognize that because they've been down that road already. And they realize that there's pain pills, there's wheelchairs, and there's total knee replacements. So when we test you neurologically and we test you orthopedically to identify exactly what's driving your knee pain symptoms. In other words, what's causing it? I'm going to sit down and I'm going to ask you questions. I'm going to say, what causes your pain? How does it feel going upstairs? Are you doing that one step at a time up the stairs and down the stairs? How about on hills? Is it just twisting? How about walking straight? What aggravates it? Does it increase as the day goes on, or does it get better? Does it keep you awake at night, or does laying down take away all the pain? That's the information that I need to know to understand which of these tests we're going to find the problems at. And then we go in and differentially diagnose which areas are the problem by seeing which areas are healthy. So when I stress the knee this way, does it cause pain out at that part? How about when we stress it this way? Does it cause pain here? How about when we compress it? How about when we bend it and push on it, pull on it? We're testing all the ligaments when we do that. We're compressing these menisci that you see in red here. How about muscle testing, meaning testing the strength of all the muscles that go across this joint and support it? I have patients that come in here and they've got weakness there, which tells me there's a problem further upstream here, probably at the spinal cord level, that's causing the weakness, so that every time they bend their knee, it's driving that femur across that tibial plateau and it's wearing away that meniscus. Now, if that's causing your problem, explain to me, please, how going in there and scoping that knee is going to do any permanent good, because it won't. If you still have weakness in those knees, whatever you do is going to continue to give you problems, including this person right here. Come take a look at this x-ray. What we're seeing here is this. This is your femur. This is that tibial plateau. This is your fibula on the outside of the lower leg. On this side, what you're seeing is a prosthesis. This is the new tibial plateau. This is the new bottom of your femur. That's your joint. You can easily see the distance in through there. So if you said, well, you know, this is getting kind of close over here, that could be considered bone on bone. This couldn't. This could not be considered that, because this is a brand new knee. So what I'm telling you is this. This is a patient of mine. This person came into the office. She has pain in this left knee, in this right knee. She went to her doctor. They did arthroscopic surgery. 6 months later, she was still in pain. They did a total knee replacement. We're going to fix this for you once and for all. We're going to replace that knee completely. Guess what? She still has pain in this right knee. Now, she's got pain in the left knee here. What is the doctor recommending for her? I'll tell you what they're recommending. The same doctor that did this said, ma'am, you've got bone on bone here. You need a total knee replacement. She says, I don't want a total knee replacement. My right knee and my left knee are both in just as much pain. How is that going to help my condition? The reason I'm showing you that is because I want you to understand what your options are. I don't want this for you. In our office, what we do is we evaluate to see what's causing the problem so that we know that we have the right person with the right diagnosis so that we can put the right treatment into effect. This instrument right here is a cold laser. This is a class 2 cold laser. It's 5 milliwatts in power. And what I do with this, I've been using cold lasers successfully since 2006 in the office, meaning getting great results with it. But I don't use this on knees. I use an MR4 deep tissue penetrating cold laser on knees. What does that mean to you? It means that this real effective laser that you're seeing right here, the other laser I use is 10 times more powerful than this one right here. And I have 2 superpulsed power heads that we use that we're literally going to put right on both sides of that knee, depending on where the problem is, to improve function. The way cold laser works is it improves circulation to the area, it helps remove inflammation, it reduces pain, improves range of motion, and it also helps to regenerate tissue, including cartilage and ligaments. That's how cold laser works. This is not a new therapy. I had somebody say to me, well, I talked to my doctor and he said he didn't know anything about cold laser. This is a doctor that works in a hospital setting. This is a doctor that does this. Why would he have anything to do with cold laser? The thing that they do is they prescribe pain pills, they do injections, they refer you to PT until it's bad enough, and then they recommend surgery. That's what they do. Ask anybody that's had a knee surgery or has knee pain, and they'll tell you that's been their experience. What our job in the office is this. Identify what's causing your problem. Find out whether or not you're a candidate. Not everybody that comes in here do I accept as a patient, because if I don't think that I'm going to really make a significant improvement in your life, I don't want you in here. I'll refer you back to pain management. I'll refer you back to the doctor for a total knee replacement if I think that's what's going to help you. My job is to find out what's the problem, apply the appropriate rehab or treatment or whatever it is, and then help you get well. Because I want you out of pain. I want you moving. I want you playing with your grandkids and your kids. I want you out walking, having a good time, doing all the things that you want to do. Because when you start to lose function in your lower legs, that's what leads to falls. That's one of the biggest problems in the senior population right now is falls and what happens because of falls. It's going to take away your independence. My job is to help you get your independence back. My name's Dr. Keith Lynch. I look forward to working with you and helping you.